Thank you so much for the nice introduction, and thank you for the invitation to be here. Sorry for causing maybe some malnutrition by having a lunch symposium, which is not easy to eat, but thank you for the introduction. So indeed, I'm a surgeon by background, so I have some friends in the audience, a critical care physician, and an expert in nutrition, and this is why I'm standing here today for you. But I come from a more clinical background, and this is what I will also talk about. So when I come from a clinical background and we take care of clinical patients, this means patients with inflammation, patients with acute triggers that you showed us can be this turning point going into real dysphagia and also be faced with temporary dysphagia. What can be the problem? Now, first of all, let's see how interesting the interplay is between sarcopenia, malnutrition, and dysphagia. It's not always the same, but there's a huge overlap of those three different phenomena. And let's have a look first into the definition of malnutrition. Because a person can be malnourished because of two reasons. First of all, it can be a lack of intake or uptake. So when you have inflammatory bowel diseases, when you have radionecritis of your intestines, when you have short bowel, there is a problem of absorption. But when there is a low intake, this can also be, the consequence can be malnutrition. And this is where the dysphagia comes around the corner. So the intake aspect of malnutrition. Secondly, when there's a low intake, the consequence is that the body cell mass will change. And what will happen is that because of the impact, not only on fat mass, but especially on muscle mass, you will see that the body will have a lower physical and mental function. So there needs to be an impact of the malnutrition of the low intake before you can actually talk about malnutrition. So the impact is the changed body composition. And this has an effect on outcome. Now, it can be from starvation, but also from advanced aging, which is the topic of today. So you can see that this definition is quite broad, but it really has all the definition is there, all the elements are there to make sure that your patients are at risk for malnutrition. So like we said, you can have malnutrition without a disease state, and this is, for example, the feeding disorders, some of those patients who don't have inflammatory status. But from the other hand, we have disease-related malnutrition with inflammation. And this is where you see cancer, where you see other diseases, and this is where the temporary dysphagia may become into line and may become part of the message. So let's talk a little bit about that. Because what is the consequence, and what is the consequence that you see in many of your patients? Malnutrition. Please think with me, did you ever saw a patient who had impaired wound healing because of, a lower intake of protein, of energy, of vitamins, of trace elements? Wounds won't heal if you're not well fed. When your wounds don't heal, you will have higher infection rates. Think about surgical patients who are malnourished. They will have more infections postoperatively. All of that gives a large burden on the patient, but also on the costs, because you will have longer hospital stay, more antibiotics. So the increased health costs are also associated with all of that. And on top of that, of course, when you see this negative circle, there will be a higher mortality for your patients being addressed. So we know the negative consequences of malnutrition. But the thing is that we play a role, and I mean healthcare practitioners in the broader sense of the word. So we all play a role because we know that it's not only the disease, it's not only primary malnutrition, it's also us. If we don't recognize dysphagia, if we don't recognize that a patient cannot eat or swallow or eat safely, there will be iatrogenic malnutrition. So many patients are faced with healthcare practitioners all the time, and still they're not being screened, they're not being detected, and they're not getting the treatment they need. So we also have an opportunity to change this and to make better results. Because you can see here some numbers of malnutrition around the world. And as we have seen, because of this combination with older age, which is rising, also more and more polymorbid patients and populations, this will probably even rise if we don't act on it. So the prevalence of malnutrition is high, and it is really a challenge and an opportunity for the healthcare society to act on it and to really help our patients on this topic, which is most of the time just another part of the disease. When we have a cancer patient, or we have inflammatory bowel disease, or we have a short bowel, the main problem might not be the dysphagia and the low intake. So everybody's looking at the other one, like whose responsibility is this anyway? But I think especially the neurologists, you know that eating and swallowing is a very important part of your responsibility. Now, I'm from Brussels in Belgium, and we had a nice study published some years ago looking especially at those Belgian older people in community and nursing homes. And this was a screening looking for malnutrition to see where is the problem. So what's the problem and where can we find it? Now, here you see some of the results. Of course, the usual suspects. Patients with cancer, but patients with dementia, depression, Parkinson's disease, already been talked about here. Look at the prevalence. Up to 1 out of 2 are at risk of malnutrition when you have dementia or depression. Parkinson, the same. And an effective state of malnourishment can be as high as 80%, or even 1 out of 10 almost of cancer patients. This is data from Belgium. I mean, we have a huge healthcare insurance. We have a very solid healthcare system, and still these are the numbers of today. So malnutrition is a battle that has not been, attached enough and not been addressed enough, because the numbers are still there. Now, if you see those dark numbers, we can only try to improve them. And I think the knowledge is there, the opportunities are there, and we are getting better. Because we understand more and more this dysphagia. And also from the European Society of Clinical Nutrition and Metabolism, when we look at this publication on terminology, you can see that dysphagia plays an important role. And once again, you see the disease states which are mentioned there: stroke, Parkinson's disease, upper GI surgery, ALS, dementia. So we know the patients who are suffering from malnutrition, and we have an opportunity to act on them. So we have dysphagia. We have sarcopenia, which has already been mentioned also, where we talk about the muscle mass. But I showed you in the beginning that the consequence of a lower intake of protein and energy is a change in body composition and a diminishment in sarcopenia because of a diminishment in muscle. So low intake will affect your muscle, and affecting muscles will lead to sarcopenia. So this is the interplay. This is the link between all the terminology. Now, we can look for it, and we can screen, and we can assess, and we can say this patient is more sarcopenic, and this patient is more dysphagia, and this more. But I like to act on things. We have blah, blah, and then we have boom, boom. Let's do something. So what can we do? And before we can do something, we have to look at the clinical reality and the implications of that. We said that cancer, but also cirrhosis patients, for example, and this is an older study, but it's still very valid. You see, once again, when you have sarcopenia, poor outcomes. 40% of the patients with cirrhosis also have sarcopenia. Look at the risk factors: older age, male, lower BMI, alcoholic liver disease. We know the profile of those patients. Those are patients that need, or not even patients, they can be in the populations. Those are people that need attention on the field of nutrition. The same is true for cancer, of course. Head and neck cancer, 20% malnutrition coexists with frailty. I have experience in doing research in oncology patients. Many years ago, we did a prospective trial, interventional trial on patients in cancer on behalf of the Belgian government. And we really implemented a proactive strategy. We measured the body composition. We measured with indirect calorimetry the metabolic rate. We did an intervention. We used oral supplements, enteral nutrition, parenteral nutrition, whatever was needed. So we show that in patients with cancer, you can actually do a positive intervention and then have a better outcome. So that's very important to know, that we don't have to look too much for the overlap. We certainly have to act on our patients. Here you see cancer, a big biobank of numbers. Once again, Frailty is one of the criteria that we were looking for. So the associations between malnutrition, sarcopenia, and frailty are not always, it's not always the three of them. There is an overlap. But like I said, you can look for malnutrition, you can look for sarcopenia, for pre-frailty or for frailty, but the most important thing is to act on it and to recognize patients. And things that can help you are components that contribute to malnutrition. Inflammation, like I said, and like we have seen by the previous speaker, an acute disease can trigger dysphagia, can, make aging go rapidly fast in a few days or hours. So this is an acute situation where nutritional therapy becomes important. Low muscle mass, weight loss, the grip strength of if you shake somebody's hand, you can immediately feel that this person is losing strength. So look at all the things that are already mentioned here as malnutrition components. But there is so much more. Those are socio-ecological models. A lot of people live alone. In Brussels, almost 1 out of 2 families are people alone. So don't underestimate that a lot of people are struggling to be fed, and especially when they get ill, if you don't have someone around you to make you some soup or to take care or do your groceries, you will end up very quickly in malnutrition. And we are seeing those people every day, and we don't always think about it, that they might need some assistance, and that all of those socio-economical aspects are also relevant in the patients. Now, I think we have created awareness. I think you all know that we can act on it. What can we do? Well, of course, we have different profiling. And what you see here is 3 different patient populations. So we have the, let's say, healthy aging. The healthy aging that has been shown that is going to be increased enormously over the upcoming years. And this is why also in Brussels, in our hospital, we have a healthy aging consultation where we screen people and tell them what to do to become more healthy, to become older in a healthier way. And one of the tests we could do is look at swallowing. Is this going to be a problem in your near future? And if it is, we can already act on it. So, of course, there you would go for modifications of the food, try different, and there we need the dietitians, try different kind of food, different structures. You could also work with oral supplements with different structures and the ITSE criteria and so on. So you have a plan for those people. When your people are at the hospital, when they become patients, we have to take care of them. And this is where medical doctors and dietitians work together, because yes, we will work with some medical foods to give them the energy and the protein that they need. And of course, some patients will be totally reliant on us for their nutritional therapy. And this is where we will use, for example, enteral nutrition. And I think that the surgeons agree with me, if you do some heavy surgery on the upper GI or on the head and nose and upper tract, sometimes those patients will just be unable to eat for certain period of time. And our surgeons, they know it very well, and a lot of surgeons all over the world know that when they do big surgery, they will already place a feeding tube or a gastrostomy or a jejunostomy so that you can bridge this period of acute disease and treatment. Because if you don't treat the malnutrition, your primary treatment will not have its optimal effect. We are facilitating the primary treatment. So different stages of disease, different profiles of people, different approaches, but a lot of opportunities for us, a lot of opportunities for the healthcare practitioners. And one of the things is also critical illness, where one of my backgrounds is, we know that when a patient has been intubated, when you take out the tube, there will be, of course, some damage, and patients will also be suffering from dysphagia, post-ventilation, post-endotracheal intubation. And this is once again something that we tackle. We want to assess, we want to know what's wrong before we can act on it and before we can safely let them eat and drink. And in the meantime, we will use medical nutrition therapy to bridge this period. In some publication very recently, dysphagia was in fact identified as a treatment opportunity. something that we have to keep in mind when people survive critical illness, because we know that mortality rates in ICU have gone down tremendously over 20 or 30 years. 75% of patients used to die, 35%. Now we only have a mortality rate of around 14%. So when those patients survive critical illness, these are all the opportunities and all the things we should look for, and dysphagia is one of them. And we also recently published an approach on what to do with patients who survived critical illness. And we also have to think about gut dysfunction. So what do we actually do when we have a patient with a transient dysphagia with, let's say, nutritional challenges? We will assess them. We will look at body composition. We want to know how much muscle they have and how much fat mass, so we can differentiate between sarcopenia or just, let's say, ordinary malnutrition. But this is nice to know. This is nice to know, but our response, our action will be that we are going to help this patient to get more energy and protein into the patient. So what I can advise you is just to use this GLIM criteria. It's very easy. I once talked to a full room of oncologists, and I got an email from a colleague in the room. Weeks later, he said, I printed this slide, put it in my consultation box, and now when I see these things, I send them to someone. If you already do that, it's fine. I mean, you know more than this, but a lot of our colleagues in healthcare just need to know if your patient had a weight loss unintentionally, a low BMI, a loss of muscle force, combined with an uptake problem, an intake problem, just as dysphagia, and an inflammation or disease. And if you have only one of the first row and one of the second row, you can act. GLIM criteria are much more complicated than this, but I like to keep it simple. I used to be a surgeon, just go for it, and I think we can safely act on those criteria. Now, is this of any use? What is going to be the result? Let's go back to those 3 patient profiles. First of all, you see a publication quite recent on dysphagia in, let's say, healthy adults. So this is the first patient group. And you can see here that using, for example, adapted food, but also thickening fluids and things that make, increase the ability for your patients to eat, indeed increases energy and protein intake. And when I take you back to this first wheel of consequences of malnutrition, you know that wound healing will improve, infections will go down, healthcare economics will be better, and mortality rate will decrease. So a higher energy and protein intake is a good thing for your patients. And you just need to use whatever you use for this kind of patient. So in this population, there is a proof. Now, we always look at stroke patients, and for me, as head of the clinical nutrition department in a university setting, I find it quite interesting how we always go up and back with neurology departments on talking about, for example, enteral nutrition or even supplemental parenteral nutrition in a stroke cohort, because I know you want to optimize the oral intake. I know you want to work hard to give the dependency back on the patient so that they can feed themselves. But in the meantime, we actually can take care of the patients. That's what we do as healthcare practitioners. So what about this nutritional therapy? And in this Cochrane library overview, the key message was that indeed it might improve daily activity. So nutritional therapy, oral energy and protein supplements might improve daily activities. But the level of evidence is not so very high. So I agree with you that we need more high-quality research to eventually prove that taking care of your patients is a very good thing. But it makes sense, and we have seen it in so many other patient populations, the surgical ones, the oncology ones, that taking care of nutritional therapy just makes a better outcome for your patients. And I'm very happy also to share this publication of my colleague, Arthur van Zanten, who just, it's not published, it's a pre-proof, also did an intervention on those patients coming from ICU on enteral nutrition. So this is the last category of the 3 patients that I showed you. And for this kind of patients, you see a nice interplay between temporarily enteral nutrition, and then going to oral nutrition, using coaching, using all the things that you can do, physiotherapy, to bring back the possibility to eat normally. But in the meantime, we take care of the patient, so you see that you can still provide enough energy, enough protein, and have an interplay between different forms of nutrition. So enteral nutrition, oral supplements, thickening fluids, and normal food, they are not competitors. They are helping each other and helping your patients to get and stay well nourished while they're battling an acute or a chronic disease. So in conclusion, there is an interplay of sarcopenia, malnutrition, and dysphagia. It is clinically relevant. It undermines the health of your patients. So we can identify it. Don't make it too complicated. Just identify patients who are at risk of malnutrition and act on it. We can. We have the possibilities. We have the knowledge. We have the motivation. You're all here today instead of lying in the sun. So we are here. We are motivated. And different patient types will need different interventions. And there we can use different means of helping them. So I think that, of course, we need more research, but please act on it, and we will have a much better outcome for our patients. So thank you very much for your attention. Thank you.